So I want to thank Val for inviting me and the whole group for hosting me here today. I'm going to talk today about a surveillance project that we have going right now. Many of you have probably heard bits and pieces about it. We call it's kind of our centerpiece of our surveillance work, called the Occupational Disease Surveillance System. I put up this definition of surveillance just to kind of stress the fact that really surveillance is not really a research effort, but it really is an effort to try to generate statistics to help drive prevention. And it really, the idea is that it really is driven as, I like this definition, which is written by John Last, who's a kind of Order of Canada epidemiologist. There's not many Order of Canada epidemiologists. So practicality, uniformity, rapidity, those are all things that we try to look for in surveillance. But we're trying to develop data systems that really can be used to help drive prevention. The challenge here in Canada is that although we have great administrative data, we don't really have large data sets with occupation in it. And our workers' compensation data doesn't really capture at all occupational disease. Only a small fraction of occupational disease is ever compensated. It's not a unique problem to Ontario. It's certainly a problem across Canada and across North America. But it is a challenge that we've had to meet. So we created this system that uses data from the workers' compensation system, primarily from compensated lost time injury claims, of which there have been many over the decades, from people in high hazard industries. And that allowed us to create what we call a workers' cohort of about 2.2 million people that we could then use to follow up subsequently for the risk of occupational disease. And we linked that to our tumor registry data, we linked it to the hospitalization data, outpatient data, and it really has given us the ability to look at a wide range of cancers. And right now we're looking at 9 different occupational diseases, several of which are part of our priorities here for the Occupational Disease Action Plan. The first one I wanted to talk about today was, though, cancer, and is really looking at diesel exhaust, which is one of the top 3 priorities for the Occupational Disease Action Plan. I'm starting off with data. This is actually not from the Occupational Disease Surveillance System. This is from CAREX Canada, but it's useful in that it tries to estimate really where are people exposed to diesel exhaust. And I think that that's another important piece that we have to inform the system, is to think about where people are. This is by levels of exposure, and it's kind of based upon our general approach that low is less than half what we think really our exposure limits should be, which is, our center had proposed 20 micrograms per meter cubed of elemental carbon. So this would be less than 10 micrograms per meter cubed of elemental carbon. That takes in most of the people involved in operating on-road equipment or smaller pieces of equipment, certainly all of our truck drivers, which is why you see so many people in trucking and warehousing. People who operate heavier equipment or mechanics might have sometimes heavier levels of exposure. So you see construction is the second biggest group here, although we do lack data in the construction sector. In fact, our center has a team out today measuring diesel exhaust in a construction site, which is why Victoria Arundale from our group can't make it here today. And then mining, which has received a lot of interest because that's really where many of the highest exposures have occurred to diesel. But you can see that overall here, when you add these up, there's approximately 300,000 people that we're estimating are exposed to diesel exhaust on a regular basis at work here in Ontario. And Although we haven't really applied a job exposure matrix to our data here, these are occupations, at least some of them, as many as I could fit onto one screen, and I apologize for a crowded screen, groups that are potentially exposed to diesel exhaust and their risk of lung cancer. For those of you who aren't used to these kind of statistics, these hazard ratios, a hazard ratio of 1 means that the risk of lung cancer is similar in a group compared to everybody else in our system. And so whenever you see something bigger than 1, that's an increased risk. And the 95% confidence limits are over to the right of those. And what you see here is almost every group that we think uses diesel equipment has an increased risk of lung cancer. Now that's complicated by the fact that in some of these industries, such as mining and construction, they may also be exposed to other lung carcinogens like crystalline silica or asbestos. But in other ones, such as truck driving or some of the transportation industries, there really aren't a lot of other lung carcinogens there. One could say that perhaps truck drivers have more ability to smoke on the job, but that's not going to create the kind of risks that we see here. So I think what we see here is pretty clear evidence of an increased risk of lung cancer across many of the different groups exposed to diesel exhaust, and not all of them are up here. And I think it also explains some of the other groups that we see even in the forest industry, such as logging, or material handling in other industries where we see also an increased risk of lung cancer. So it is an important cause of lung cancer here in this province. Another priority for the occupational disease surveillance system is allergens and irritants, and so that means asthma and dermatitis. Certainly asthma is one of our 9 diseases that we are looking at here for in the occupational disease surveillance system. The American Thoracic Society estimates about 15% of all asthma is either caused or exacerbated by work. And the American Thoracic Society is hardly a radical organization. It's probably the most respected, one of the most respected respiratory professional organizations in the world. So when they came out to a statement like this, it really underwent a lot of review. So a large proportion of asthma, which really affects probably about 10% of adults in Canada and in most industrialized countries, is caused or exacerbated by work. What we tried to look at was actually what's called new onset asthma. So we tried to use an approach that would where we looked at people who had at least no history of asthma in the 3 years prior to when they entered into our system, and then try to see who developed asthma afterwards. And here you see some of the kind of typical groups that we might expect here. Painters in manufacturing, particularly where we might be painting things such as metals, you have a higher risk of exposure to things like isocyanates, but other chemicals probably as well that might be causes of asthma. We see an increased risk among people in baking and confectionery work, where flour dust has actually been associated with asthma. We see some evidence for an increased risk for cabinet and wood furniture makers, which makes sense because wood dust is another established one, and we don't necessarily see it in construction or some of the other wood industries, but we do see it there. And then we see it in some other groups as well, some evidence in janitors and cleaners, and we certainly have some concerns about cleaning agents, some in some healthcare workers and others here. So we're going to discuss more of these specific results, I hope, in our when we have our breakout sessions later today. Contact dermatitis is another one that we've looked at in our data. Contact dermatitis, although people have used what we call administrative data, the kind of routinely collected health data, to look at patterns of asthma. It's been used less commonly for things like dermatitis, but we used very similar approaches with dermatitis to look at new onset, basically, or new cases of dermatitis in this data set. And again, we'll have more detailed results of that later. But you see certainly evidence of it in some of the typical groups where we would expect it. People who basically have to wash their hands frequently or operate in kind of wet operations, and in food services where they have to wash frequently. Barbers and hairdressers, which is another group where they have both chemical exposures, but also one could consider it a bit of a wet operation as well in terms of frequent hand washing. Some manufacturing sectors, people in metal machining where there's metalworking fluids, furniture and fixtures where again there are allergens available or there from wood dust. Some evidence in health and medicine, and then some interesting results that periodically pop up, such as dental hygienists there. So we are seeing a lot of different groups in this, and our system, because it has hundreds of thousands of workers in it, allows us to really look at fairly narrow definitions of occupational groups. Allows us to look at that kind of level, I think, that really can inform our looking at prevention. You have to excuse me, I'm speaking fast because I know we're already about 20 minutes late, and it's a little hard to catch up with this, but I'm going to go through a little bit quickly. The Occupational Disease Action Plan currently has three kind of priorities. One is noise, one is allergens and irritants, and the third one is diesel exhaust. But fourth and fifth on there are asbestos and silica. So I'm just going to give a few results in that area as well. Asbestos, it's unfortunate actually that we haven't been able to move yet and put that in a priority area. A few weeks ago, Canada legalized pot. And that was the big news, and unfortunately, people, unless you were really paying attention, you didn't hear that they finally passed the asbestos ban on the same day. Kind of unfortunate timing that I don't really understand if you want to make a splash with a good news story. But by the end of this year, the asbestos ban will be in place, and I think we should be trying to use whatever coverage that gets to try to push the message that we still have a lot of ways to go to prevent asbestos-related disease. Minds have closed. Asbestos ban is in place, but even the asbestos ban, when you read the full stuff that's come out of the federal government, they were asking us, in order to justify the cost of that, well, can we predict, in 30 years that we're preventing 5 cases of asbestos, related cancer per year? 5 cases, that's what the ban is. And we said, well, that's, they asked both Emil Tampa, who's our economist on some of the work we've been doing, and I about that. And we said, well, that seems reasonable, but there are literally, probably more like several thousand cases of serious asbestos-related disease, either mesothelioma that's rapidly fatal, lung cancer that we still don't survive all that well with, things like asbestosis, other cancers per year. So the ban is an important step. It's a necessary step. It'll make a difference in decades to come, but asbestos is not going away. And what that looks like is this within our system, where you look at mesothelioma and asbestosis. So where our risks before in diseases where we say a percentage of it is caused by work-related disease. What you see here are very big risks when you're talking about things that are almost only caused by workplaces. So if we look at the classic groups, insulators, plumbers and pipe fitters, boiler makers, you see very, very large risks of mesothelioma and asbestosis. Now, our system excludes people who entered the system with a claim of these diseases. So it somewhat underestimates the groups that we know a whole lot about. And still we see these very large risks here across not all construction jobs, but most or many construction jobs, and certainly some other groups where we would have concerns, and maybe they're not getting necessarily recognized as much. Mechanics, industrial farm and construction mechanics have an increased risk. Stationary engineers, lots of other groups out there have an increased risk of asbestos-related disease. And you see this, those were occupational groups, these are industry groups, and you see here non-metal mines. You know, we used to have some asbestos mines here. They weren't long-lived here in Ontario, but we did have some. But also the mining industry takes in, you know, it's cyclical. There's mines go up and down, and so miners move for different sectors. So we do have miners in our mining industry who came from asbestos, where the mines are still operating. And so you see a large risk of mesothelioma there, even though our Ontario mines closed a long time ago, back in the 80s. Non-metallic mineral products are the manufacturing sector where we used to make products containing asbestos. And you certainly see continued risk of asbestos-related disease there. You see in construction less risk among general contractors, but the specialty trade contractors overall, in terms of industrial sectors, is where we see that large increased risk of asbestos-related disease. And one of the groups here that we've talked about, I think, or health and safety professionals have, but I still think is under-recognized, is we have educational and related services here, where there's evidence of an increased risk of both mesothelioma and asbestosis. And the people in the system that we have are people who basically had a lost time claim for an injury. So that's much less teachers than it is our custodians and all the skilled trades people that maintain our schools. And every school in Ontario that's probably older than about the mid-1970s has asbestos in it. Probably all of our hospitals do, all of our public buildings do. There's lots of asbestos still out there. It's going to remain out there for decades to come. Remove the lagging around pipes in our schools, but that's about where the funding to remove asbestos ended. Now, we said we're going to cause more harm than good by trying to rip out all the asbestos from buildings. That was true, and that's what I was taught back in the 1980s when I became a hygienist. But those buildings are now 30, 40 years older, and gradually they're going to be deteriorating. So we have to address this problem as it goes forward. Our system allows us for some jobs to look at what the risks are over time. And what we hope to see, for instance, is something like the non-metallic mineral products. So we hope to see the risk of asbestos-related disease going down over time, but in fact, it's relatively flat. Now, these are what we call long latency disease. They take a long time to occur, but we don't really see a pattern that these high-risk groups are going to be are showing any evidence of becoming lower risk over time, at least in our data, with some exceptions. The next group I wanted to talk about was silicosis. This is another one that we've known about a long time. I can't remember whether it was fourth or fifth, or asbestos was fourth or fifth on our list, but this was also on our occupational disease list, silica. What you see here are the risks in groups here where we would actually expect drilling and blasting, clay, glass, stone processing, lots of groups where we expect silica to be. Certainly in metal mines, we have high levels of silica in uranium mines and gold mines, and a number of our mining areas and in our quarries and things like that as well. So we definitely are seeing this increased risk of silicosis in a lot of the groups. One of the things we've been trying to apply into our data using kind of an approach that we're getting assistance with from the CAREX project that we worked very closely with, is really trying to classify jobs according to their potential for silica exposure, and what these jobs are classified either by probability of exposure, being low or moderate or high, or the percentage of people exposed to crystalline silica. And so we're going to be using this approach increasingly over time with our surveillance data to focus things on the exposures, but in fact for prevention, knowing the occupations and the industry sectors I think is also very useful. But this is just to say that we get a very clear signal with this new system and the data that we're generating. Lung cancer, I mentioned construction a couple of times here. You certainly see it for diesel and silica and asbestos. So this is just to show you that we do see an increased risk of lung cancer across construction for these various different exposures and different reasons. So we certainly are seeing a lot of the expected results in this data, but we're getting very, very clear signals on this. And we're trying to look, and we're hoping to see more of these trends. Now, in lung cancer, we have bigger numbers than in asbestosis and silicosis. But what you can see is in lung cancer, drilling and blasting is good news, right? So maybe in drilling and blasting there is more attention being paid to silica, but in excavating, grading, and paving we see things rather flat with the risk of lung cancer. And some groups we see going up. Truck drivers is of concern for diesel. And janitors and cleaners is one that we didn't expect as well. So anyway, this is just to give you some very quick examples of the kind of data that we now can generate with this system that we've created, and that is really ready to, I think, for prime time at this point. And the ways that we hope that it will contribute to prevention are, I think, multiple. One, at a very basic level, is convincing our system partners or key stakeholders, the people who are represented here, of the importance of some of these issues, and having people be informed with numbers and facts and figures and statistics to go forward and to push for policy change, to push for organizational change. We certainly want to use that to encourage workplace level actions to reduce exposure, and to really to target our prevention activities, really ranging from basic education all the way through kind of targeted enforcement. So kind of a wide range of things. So we believe that surveillance will have a key role, and I think you'll hear more about that later today from other speakers. I don't need to tell this group here who our key target groups are. I think there's representatives of all of these different groups here today, but those are our key targets for this system. We're trying to create knowledge products. We've been slowed a bit by the unfortunate timing that at the same time that we started getting increased funding from the Ministry of Labor and the Ministry of Health and Long-Term Care, we came under some restrictions in terms of hiring and starting new initiatives and things like that. So we're moving a bit slower in the development of knowledge tools, but that really is our goal with this, both to kind of create kind of targeted tools that highlight key results that could be developed for different sectors, kind of in collaboration with our partners, things that really kind of present our data. And you don't need to look at the specifics. Those have been evolving over time, but we're really trying to do more of that kind of thing. But one of the key things we're also trying to develop right now is a website that will also allow people to directly go and even to query up and pull up statistics for different sectors. And that's also on our list for this year. And we still will, I think, do it in this fiscal year. It just may not be very pretty in the end. But at least we hope that we'll get a functional website up and going. So in conclusion here, quantifying the impact of our hazardous exposures, I think is a necessary step if we want to start making evidence-based decisions about prevention. And although I think we know a lot about exposure in terms of, I would say, a qualitative way, really trying to get numbers and to assign levels of exposure, to say where people are exposed, and to say what the impact of that exposure is really a key gap that we really need to fill, and I think we're moving towards that now. I want to just end with, these are some of our key staff involved in the surveillance project at this point, several of whom are here today, Sharara, Chloe, and Kate. So feel free to ask them about what we're doing. I also wanted to thank, we've had a lot of help from different folks, and I don't think I got everybody's name on there because I was doing these yesterday in a hurry as typical, and but certainly we've gotten a lot of advice over time from Val, from Nick, who I think is going to be here, from other people who are involved in this group, as well as a wide range of other clinicians who are specialized in this area. So with that, I think at least I haven't put us further behind. Thank you very much.